Ladies and gentlemen, thank you for joining us this evening for the Pink Agenda's TPA talks on the Pink Agenda's TPA talks on the agenda, Disparities in Breast Cancer. Please welcome Leadership Council member Shayla Martin.
Hi, how's everyone doing today? So good evening and welcome to TPA Talks on the Agenda. Tonight's topic will be disparities in breast cancer. I'm Shayla Martin, and I'm proud to be a member of the Pink Agenda's Leadership Council and to serve on the Athletic Endeavors Committee. If anyone here ran the New York City Marathon on Sunday, congrats. I hope you had a great time running through the best city there is. Raising awareness about tonight's topic is especially important to me as on October 9th, I marked 3 years cancer-free. In December 2017, I was diagnosed with breast cancer after finding a lump via scratching a mosquito bite on my upper breast area. Although I still don't fancy mosquitoes, this one in particular probably saved my life. From there, January 2018 through October 2018, I embarked on the breast cancer journey. I went through a single mastectomy, chemotherapy, reconstruction, and radiation. And just about a year ago, I had my third reconstruction. To say the journey is life-changing is an understatement. I learned things about myself that I don't think I would have learned without breast cancer. Those things are definitely a story for another time, but I can tell you this: there is before cancer Shayla and there's after cancer Shayla. And boy, oh boy, do I love after cancer Shayla. And because of my personal journey, I believe that knowledge is power. And I joined the Pink Agenda this year to contribute to its mission to raise awareness of the disease amongst my peers. We know that the breast cancer journey is unique. Treatments are not the same, and friends and family who are diagnosed prefer different types of support. Researchers funded by TPA and our partners of the Breast Cancer Research Foundation are investigating new ways to prevent, treat, and cure this disease from every angle. We created TPA Talks to showcase these perspectives, and now with TPA Talks on the agenda, we're diving deeper into breast cancer topics that are especially relevant for our supporters. These events would not be possible without the leadership of the Pink Agenda's Education Committee. Thank you to each and every one of you, or the support of tonight's sponsors, Kendra Scott and Santander. We are always so grateful for Kendra Scott and Santander's commitment to breast cancer research and giving back in a meaningful way. We thank you so very much. This year's headline news is that breast cancer is one of the most commonly diagnosed cancers in the world. I want you to pause and think about that for 1 second. Breast cancer is the most commonly diagnosed cancer in the entire world. It is clear that our work is not yet done. More alarmingly, within our community, there was a 32% increase in metastatic breast cancer diagnosis in women aged 25 to 39 between the years 2009 and 2015. I'll repeat that one more time. Increase between the ages of 25 to 39. That's before the age that the insurance typically will cover breast mammograms. That is huge. The Pink Agenda approaches these major problems in 2 angles: through research we fund and through educational programming designed to reach this population. Tonight, we ask you to join us in moving this work forward. At any time, you can take out your cell phone, just like this, and text the phrase TPA Talks, no spaces, that's TPA Talks, no spaces, to the number 44321. Once again, that's 44321. And from there, you'll receive a secure link to donate. This phrase and phone number is also listed in the digital program booklet. We're so fortunate to have incredible panelists this evening and know they will inspire you to be part of game-changing progress. So thank you in advance for attending. I'm looking forward to this conversation, which will be moderated by Trish Michelle. You're going to love her. Trish is a breast cancer thriver and advocate also. Diagnosed with invasive ductal carcinoma at age 36, Trish knew that she needed to put her health first and wanted to bring visibility to her journey, so others going through treatment would know that they are not alone. She serves as an ambassador for the New York chapter of the Breasties and is co-founder of Hip Hop Happy Hour on Instagram. I highly suggest you check it out. That Trish works tirelessly to raise funds, awareness, provide representation, and is actively working to create an inclusive and progressive movement towards equity, particularly for those fighting cancer and other chronic illnesses. It is my pleasure to welcome Trish to kick off tonight's conversation. Thank you, Trish.
Thank you so much, Shayla. I appreciate it. I'm so thrilled to be here. My journey began like a lot of us in our age. I couldn't put my finger on what was wrong. I had a physical and passed with flying colors, maybe a little low vitamin D or iron, but I just felt something was off. And like I said, couldn't put my finger on it until I put my literal finger on the lump. And it changed my life. I got the diagnosis, and then it's like numbers, right? One mastectomy, treatment, radiation. And so all in all, it's been 5 years of no evidence of disease. And I'm committed to just being in there, trying to make a difference in the way that I can. So I like to say so much about cancer is trash, garbage, terrible. But what it does give you is some clarity and gifts of community and partnering with a great organization such as the Pink Agenda to bring this necessary conversation to the forefront. So thank you so much for having me. Let's get started. We're here to talk about the gaps in breast cancer, incidence, care, and outcomes. And we'll examine the work being done to eliminate them. As a survivor and patient advocate, well, frankly, as a Black survivor and Black patient advocate, I can tell you I have seen the gaps and disparities right before my very eyes. So this year, for the first time, breast cancer has surpassed lung cancer as the most common cancer worldwide. Globally, an estimated 2.3 million women will be diagnosed with the disease this year alone, representing the largest number of cancer diagnoses after non-melanoma skin cancers. In the US, Black women are more likely to be diagnosed with breast cancer at younger ages, and these diagnoses come at later stages of the disease. Black women are also more likely to be diagnosed with triple-negative breast cancer, one of the most aggressive forms of the disease and one that lacks targeted therapies. Most alarmingly and unjustly, Black women are 40% more likely to die from breast cancer than white women, despite being diagnosed at similar rates. Black breast cancer patients have fewer opportunities to participate in clinical trials and often face more limited access to quality healthcare and early screening. Despite lower incidence rates, Hispanic and Latin American women are more likely to be diagnosed at later stages, in many cases due to lower mammography rates and lack of access to healthcare, be diagnosed with aggressive breast cancers like the triple-negative breast cancer I mentioned earlier, and be disproportionately underrepresented in research. Latin American women have the second highest prevalence of BRCA1 and 2 mutations after, of course, Ashkenazi Jews. Breast cancer is the leading cause. Breast cancer is the leading cause of cancer-related death for Hispanic and Latin American women. So you see, it's important that we have this conversation today. And I am so fortunate to have a truly esteemed panel of experts with us to discuss these deeply important topics from every angle, bringing the perspectives of the doctor, the researcher, the survivor, and the advocate. So I'll start by introducing you to one of our great panelists, Dr. Lisa A. Carey. Dr. Carey is a medical oncologist and the L. Richardson and Marilyn Jacobs Pryor Distinguished Professor in Breast Cancer Research in the Department of Medicine at the University of North Carolina. She is also the Deputy Director of Clinical Sciences at Lineberger Comprehensive Cancer Center and an investigator supported by the BCRF. Dr. Carey's research focuses on understanding the evolution of breast cancer metastasis to improve therapeutic strategies and identify new drug targets. Dr. Carey has served in many roles for the American Society of Clinical Oncology, the American Association for Cancer Research, and the National Cancer Institute. Woo! Welcome, Dr. Carey. Amazing. Thank you so much for being here.
Thank you. It's a pleasure.
So next up, we have Dr. Dawn Hirschman. Dr. Hirschman is a medical oncologist and director of breast oncology of the Herbert Irving Comprehensive Cancer Center at Columbia University Medical Center. Her research, supported by the Pink Agenda through BCRF, focuses on identifying ways to improve cancer care delivery, quality of care, and quality of life for patients with breast cancer. Dr. Hirschman is also a professor of medicine and epidemiology at Columbia University. She has published over 450 scientific manuscripts and has received several grants and rewards recognizing her work in cancer treatment, prevention, and survivorship. Hi there, Dr. Hirschman. Welcome.
Thank you for having me.
Excellent, excellent. Now, rounding out our incredible panel is Alejandra Campoverdi. Alejandra is a nationally recognized advocate for women's health, a member of the Medical Board of California, and a former Obama White House official. An influential patient advocate for breast cancer and BRCA awareness, she is the founder of the Well Women Coalition, an initiative empowering women of color to have agency over their own health through awareness, education, and advocacy. Alejandra also founded Latinx and BRCA Awareness Initiative in partnership with Penn Medicine's Vassar Center for BRCA. She produced a PBS health documentary called Inheritance, which follows the surgical journeys of 3 women as they confront their hereditary cancer risk. Great to see you, Alejandra. Welcome.
Thank you. Great to be here.
Okay, thanks everyone for being with us tonight. This is going to be a fantastic and important conversation. So let's start by addressing the question, Dr. Hirschman, what disparities exist in breast cancer outcomes?
Well, you summarized it really, really well. And, I think, there are things that we know and things that we don't know. And I think one of the things that we focus on is when we think of outcomes is how long do people live when they're diagnosed with breast cancer. And we know that African-American Black women are less likely to live a full life, regardless of the stage that they're diagnosed, even when you account for the biology of the cancer, that their cancer, when they're diagnosed with early stage disease, is more likely to come back. When they're diagnosed with metastatic disease, they don't live as long. And we know that there are other outcomes that are super important as well as survival. We know that African-American women are less likely to be treated for pain. We know that they're less likely to have important supportive care. And they're less likely to be offered all of the same types of modern treatments as their non-Black counterparts. What we don't know always is why. And when we think of this, we have to think of the whole spectrum. Is it related to the diagnosis, not having access to screening? But we know even stage for stage that the outcomes are not the same. Is it related to the type of treatment that people get, or the quality of treatment, or the completion of treatment? Is it related to delays in care or intermittent gaps in care? Or is it related to underlying biology that can affect how well the treatments work or how the cancers develop? And so there's a lot of work trying to help untease these things so that we can figure out what factors we can modify so that we can shrink that gap. And we know we are making progress in shrinking that gap, but we have not made nearly enough.
This is amazing because, Doc, I will tell you that it's almost like you're just gaslit. And so there are numbers that support what you're saying, correct? So it's not just, the word on the street is, there's actual numbers that support what you're saying, that these
Yes.
disparities and gaps exist.
Yes. And it's
Wow.
been something that I think, people have been researching for over 20 years. In fact, it's fascinating because until we had good screening and until we had good treatment, there was no difference. There was no disparity in outcome. But until we started to be able to do something about breast cancer, that's when that gap started to widen and widen in terms of how well people do after diagnosis.
Wow, 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 wow. Thank you so much. I'm going to switch to you, Dr. Carey. What do we know about the biological differences of breast cancer in Black women? And also, are there differences for Latinx women?
We do know something about it. And I think, what Dr. Hirschman was just outlining is, sort of this emerging sense that these disparities can come from different places. Like it's likely that disparities in outcome, by race in the US comes from a bunch of things that are contributing. And we have to unpin them all and then figure out what we can do about each of them. And I think there is a biology element here. So what we know is that a Black woman or a younger woman, regardless of race, who gets breast cancer is more likely to have a kind called triple negative, which is a kind that does not have hormone receptors or HER2, which means that we don't have targeted therapies for it at this point. And it is our most aggressive subtype of breast cancer in the current era. And so, if you think about it, if you're a young Black woman who gets breast cancer, that's a double whammy, right? And in truth, the likelihood at any age of a Black woman having a triple negative breast cancer, is substantially higher. And if you look on the molecular level, it's actually doubled, the molecular part of triple negative when you start to get into the deeper biology. And it's a zero-sum game, right? So if you have more of the poor prognosis kind, then you must have less of something else. And the thing that they have less of is what we call luminal A, which is our best prognosis group. There's, if you consider molecular subtypes and even clinical subtypes are broken down into about 4 groups. The best is luminal A, and that's the one that Black women have the least of. And the worst is basal-like. Now, these are relative things, right? Because anybody can get any kind of breast cancer. And Dawn knows this, and I know this from our clinic. But once you start finding that the distributions of more aggressive cancers start to fall into these categories, that certainly has to be part of the story. I think there are fewer data in the Latinx community. What exists is that it looks like there's also some disparities there, although it's not as clear that it plays out in prognosis and survival in the same way as it does in the Black community.
Wow. Okay. Thank you so much, Dr. Carey. I'm going to switch over to you, Alejandra. What do you hope to achieve through your work with the Vassar Center for BRCA mutations? Mute. You're on mute.
Just notice, thank you.
It's okay.
First and foremost, awareness raising in the community. I do want to touch on some of what was said because, a lot of times the Latinas get erased in this conversation. And when we're talking about women of color and aggressive cancers and prognosis and treatment and all of that, that's very inclusive of the Latino community. And because of our underrepresentation in research and so on, a lot of times we don't discuss that as much. And so that's one of the big motivators of why it is that I'm here and why it is that I started Latinx and BRCA. So I just, I want to start by saying that. When I was first found out that I was BRCA positive, I looked online and didn't find a lot of information that seemed that it was tailored to Latinas, let alone information in Spanish, let alone genetic counselors who could speak Spanish, and so on. And so that's one of the reasons why I partnered with Penn Medicine's Vassar Center to create educational materials that were bilingual and to start having conversations that were culturally relevant to the Latino community. Because when you look at the fact that we have about 1 million individuals who have BRCA mutations in the US, but only about 10% know. You can imagine how much smaller that number is for women of color, and especially if language is a barrier. So we're very new in our initiative. We started about 2 to 3 years ago, but our hope is to really spread awareness, create educational materials that can be used in clinics, which we distribute in that sense, and also create resources so people can find genetic counselors that, again, have language proficiency in different languages.
That's wonderful. I didn't interact with any kind of genetic testing or even have these conversations until I was diagnosed with cancer. So I think it's great to raise awareness and to have people, even if you don't subsequently have the test, but to have the conversations to find out, did grandma really die of natural causes or was it breast cancer? So that you have that information and you're armed, right? When you go into these appointments, knowing that there's a history there, or you can have a fuller conversation with your medical professional. So that's fantastic. Dr. Carey, what exactly is triple negative breast cancer, and why is studying triple negative disease particularly important for Black and Latinx women and men?
Yes.
I have to say that too, you know?
Yeah, 100%. Yes. Men can get breast cancer, not as commonly, but certainly can happen. And we all have them in our clinics, and blessedly we can care for them equally. So, triple negative, I alluded to a little bit earlier, is the subtype that doesn't have hormone receptors or HER2. And that's important because hormone receptors, we've had drugs for years to help fight cancers that have hormone receptors on them, right? All the anti-estrogens that we've had, and we have more and more of those, all the time. HER2 used to be, a HER2 positive breast cancer used to be the worst kind of breast cancer because it was very aggressive. What HER2 does is sort of turn the tumor on, until we got anti-HER2 drugs. And now it's one of our best prognosis groups because the drugs we have are so effective. We don't have any of that kind of targeted therapy. And in part, if you think about it, the name triple negative is a clue to the problem we have. It's defined by what it isn't, which is not very helpful when you're trying to come up with targeted therapies and good, treatments. So the importance of this is, it's overrepresented in Black women. So it is a major cause of preferentially of poorer outcomes in Black women. Number two, we don't understand it that well, right? Because it is actually probably a pretty heterogeneous group of tumors that themselves may have targetable abnormalities, but we haven't figured that out yet. So everything is dumped into a basket, and it's not very helpful. So that's why it's really important, because it's poor prognosis. It is overrepresented amongst women of color who get breast cancer, and there's a lot to be done. We really have a big gap in treatment options for it.
Lots of work to be done about that, for sure. Dr. Hirschman, you had talked about it a little bit before, but what is a little bit more about the social determinants of health impacting the outcomes for Black and Latinx women?
Yeah, sure. So social determinants of health are really non-medical factors that influence your health outcome. And we've learned over time that these factors can really contribute substantially to health inequities across the border. We know that African American and Latinx populations are more likely to have, to live in poverty. And ultimately poverty and all of the other things associated with it, can affect the care that you get and how you respond to the care that you're given. So when we think of them, we think of specifically factors like income and how protected you are from having treatment impact your finances. We think about education and health literacy, employment, and whether or not you can get food, or what we call food insecurity, so that you don't have access to good nutrition, or live in housing where you're secure about some of the basic things that you need to take care of your day-to-day life, or your kids, or the rest of your family. But it also incorporates stress and social conflict. And we know that lifelong exposure to stress in the environment can have negative impacts on one's health. And it can be a little bit of a catch-22, where we don't know if all of those factors together can influence the biology of a cancer that you develop. So, because we know that like weight and obesity and exercise can all affect your likelihood of developing cancer. But all of these other factors, things that we sort of group together in terms of calling it allosteric load, is a term that's commonly used, of all that stress sort of bundled up into one, and how that might affect how cancers develop, and the age at which cancer develops. So all of these social determinants affect your likelihood of developing cancer, possibly the type of cancer you develop, but they definitely affect your outcomes once you develop breast cancer. We did a study last year where we looked at something called the area deprivation index. So how likely you are to live in poverty, which is an area that has all of these factors: housing, food, poverty, all together. And if we looked at women that were on clinical trials, so they all got the exact same high quality treatment. And even if you get the same treatment, you're more likely to die of your cancer if you live in an area where there's, a lot more social deprivation. And that's something that we could probably impact, so these factors do have a big, influence on how well you do. And not just your breast cancer health, but your overall health, like your cardiovascular health and all the other things that are important as well.
And maybe, it's not a controversial statement, but, it's important too for the medical team to have that in mind when they're seeing the patient. So it's like you're taking a holistic look at the patient, because you might see, let's say it's someone like me that comes in and you're saying, oh, that patient, she's non-compliant, or she doesn't show up to appointments, or she's late, or whatever. But you're not thinking like, the place, the center is off the grid, and I had to take 4 buses, and no one could watch the kids, and these things play a role. So it's not non-compliance. It's like life is getting in the way of my treatment,
Right.
And so you hope that your health team has, maybe empathy is the word I'm looking for.
Let me make a quick comment about this, because I think this is an incredibly important part of the story. And I'm like the biology square in our little thing. But I'm going to say something that I think is really crucial here. I can talk about triple negative, and it is overrepresented, but in Black women and in white women, most breast cancers are hormone receptor positive and HER2 negative. That's the dominant type, regardless of race. And when you start to look within these subtypes for where the greatest racial disparity in outcome exists, it's in hormone receptor positive HER2 negative breast cancer. So what is it about that disease? That disease requires longitudinal care and drugs that are given over several years, which means you have to have access to the drugs. You have to be able to pay for the drugs. You have to be able to get to your appointments. It is a different, so listen, I'm not underplaying the importance of these really poor prognosis, aggressive things, but the truth is that probably is much more in the social determinants of health services research in terms of things we can do to actually fix a disparity, is probably in that group. And that's where it's almost a double mortality.
Wow. So important. This needs to be isolated so that folks, because we talk about it in a roundabout way, but we've never thought about it in such a way. And that's exactly where you can see like the fork in the road, in that, yes, because I have hormone positive, HER negative. And let me tell you, I thought I was done with treatment when I was done with treatment. No. The journey continues. And so, there's a lot of follow-up appointments and things of that nature. Very important, very important. Thank you so much for talking me through it, because I was like, should I mention it? But I'm glad I did. Alejandra, there are cultural barriers that exist in achieving better outcomes for Latinx women. If so, how can we address them? Are there?
Absolutely. It's a great question. And in addition to all the social deterrents have been said, I always point to this story of when I was making the film Inheritance. I went to go visit different free clinics on their free mammogram days in LA. And I was talking to the caseworkers there, about what they hear about the reasons why these women come in for free mammograms or don't in a very predominantly Latino area. And something that they said that they had seen more often than they'd like to is Latina women coming in and learning that they had breast cancer, learning that they had to have surgery, be it a mastectomy or a lumpectomy, and them coming in with their entire family and generations of people in their family and their husband and their cousin and their abuelita and their kids. And the fact that often they would hear from the men in the family saying, well, a mastectomy is off the table, right? That's not something that that we want to do, as a group decision. And, I think that it's something to understand about the Latino community that a lot of times, oftentimes, I know in my own family, it is a generational cultural experience. When I found out I was BRCA positive, it rippled all the way up and down generations of my family. And so when you look at barriers, you are looking at educating an entire family many times, and educating generations of a family, as well as, different religious ideas about your body and testing and so on. And so whenever I think about how to do awareness raising and be culturally sensitive around the Latino community, a lot of it is messaging around the responsibility a lot of times that the younger folks in the family have around, talking to, again, their parents and their grandparents and their aunts and uncles, and really being able to spread that awareness in a way that is coming from a trusted source where everyone feels included in that conversation. That's, I don't think that's only unique to the Latino community, but it's particularly true in our community.
No,
So
absolutely.
if you don't include everyone, then that's not addressing that barrier.
No, you're absolutely right. My parents are from Haiti, which is in Latin America. My parents, and it was like the White House Situation Room when we would have to make a decision that like mom weighs in, my grandma weighs, everybody weighed in, and I did go almost to war with them about choosing to have a double mastectomy because they felt it was too far aggressive of a decision. And I think it's my decision and my body, but it's just, they just feel like it's a cultural thing. It's that your body, you're born, God makes you intact. And so any kind of deviation from that is a, so yes, they definitely could benefit from that kind of education because it's difficult when, your support system, all that is driving you one way, but you as the younger generation feel like you want to go another way. So it's important. I wish I had you to help me bridge the gap because it was loggerheads the whole time.
Well, if I could add one last thing, is that it's been one of the more meaningful experiences for me is after finding out I was BRCA positive and that kind of rippling in my family, my mom and my aunt have had their ovaries preventively removed. And, you don't realize that the effect that can have, and whether or not they spared themselves an ovarian cancer, we won't know. But that's not something that they would have ever even imagined doing something preventively like that. So when you think about it that way, there really is a big, meaningful impact generationally.
Absolutely.
I think you bring up a couple really, really important points in terms of us as providers understanding, all of the factors in the community that we serve, and all of our communities are different. I'm up in Washington Heights, and we have, obviously take care of a diverse patient population, but we have a very strong Dominican, and you have to understand, population, you have to really understand the culture in order to understand, what things to offer when somebody's having a hard time making a decision, and having like the advocacy community and knowing how to reach out to help people so that they can, talk to people just like them makes a huge difference. And I know Lisa's in North Carolina. It's a very different patient population. So it's up to us to try to figure out how to pull in those resources to help people.
Absolutely. Cultural competency is like So important. And so, yes, I agree. Dr. Carey, looking at you, why is research participation, that is in participating in clinical trials, why is that so important for Black and Latinx women? I mean, I know the answer to this, but I'm going to let you say it too.
Well, listen, it's important for everybody because
Mhm.
we are where we are with a, 40% improvement in outcomes when breast cancer writ large over the past few decades because of research that showed us the way to do things better, right? Everything we know how to do, everything we've talked about came out because people participated in research to show that it was better than what we were doing before. That's the only way forward. It's the only way to know. So you have to be part of the solution if you want the next generation to have a different experience than you did. It's particularly important for Black and Latinx women for the reasons Alejandra was saying. They're underrepresented. They're underrepresented in trials. Many of the trials are performed in places that have a much larger white community than they do, a reasonably proportioned community of people of color. And so they end up not being included. And if you don't include them, then we will not have the knowledge to know if we can make assumptions that something that behaves one way in a white population is going to do the same in a Black or a Latina population. I think we've learned the hard way that we ignore, or we generalize from a white older woman population at our peril, right? We know it isn't the same. And I think, for simple, reasons of if we want advances to happen equally in all of our patient populations, but if they don't get studied, then we won't know if we're doing it right.
Absolutely. Absolutely. I know that I was in a study, but I kind of had to, do some detective work in order to get it. And it was mind-boggling to me. I mean, I heard it as a part of a conversation. Are you in a clinical trial? I'm like, what's that? What should I do it? Maybe, and so I had to look around, but I was thinking of, grandmothers and older people because they would say, oh, go on this website. It's like, I know we're in a society where the phone is right here, the internet, but not everyone is internet savvy. So if you're not internet savvy, if you're not in the loop, it's difficult to participate. And so I wish there would be more joining together of those communities and those opportunities. Wouldn't you agree?
100%. And I think
Yeah.
that's really on us to figure out ways to engage patient advocates to help us bridge, because many times the trials and the populations we want to make sure are included are just not physically in the same place. So we're not communicating. I mean, communication is key. Cultural competency is key. We've learned also that, knowing who and how you present a trial matters. There's a trust element to going on a clinical trial. If someone who understands you and where you're coming from and the challenges that might be unique to where you are coming from is the person talking to you about it, you're going to have a lot more faith that they actually are thinking of you, not just the trial, as they're discussing it with you.
Absolutely.
And I think as a research community, we make assumptions. This person's young, they have a lot on their plate, they're not going to want to participate in a trial. We're not going to even approach it because we don't want to upset them. And I think in recognizing our own biases, and having this issue come up a lot, it's making us, challenge those things and figure out new ways to do it. And if it's figuring out how to use technology or advocates or whatever, I think the awareness is the first step, so that we can broaden our access, because then at the end of the day, we'll be able to answer questions much faster.
Absolutely. We all benefit, right? COVID has had a devastating impact on minority communities and especially the Black community. Dr. Hirschman, has there been a trickle-down effect extended to women experiencing breast cancer or at risk for breast cancer, like delays in screening and such?
Yeah. There's no question that, during that period of time, that when everything was closed down, that delay in diagnosis is going to have an impact on cancer outcomes. I think where all of the modeling experiments of, what's going to happen has shown that cancer patients are effective. I think, if you are in the right place at the right time and
Mhm.
have the right access, maybe your doctors could figure out how to take care of you remotely, or you could get the care that you needed. I think that's not true for everybody. But now I think is the time to come back, and now it's safe, and we know how to screen people, and we're much more effective at making sure the environment's safe for people. So now that so many people are vaccinated, the message is, get the care that you need. Breast cancer, colon cancer, cervical cancer, whatever is out there from a prevention perspective, now's the time to go back and catch up on all your health care.
Absolutely, absolutely. Alejandra, as Black and Latinx women are more likely to be diagnosed at younger ages, what are some of the unique quality of life issues that need to be considered upon diagnosis?
Well, I keep coming back to a sense of belonging for women of color after diagnosis, because as we know, there's so many factors, so many decisions, and so many pieces of this that are around a sense of community, from feelings of isolation and being able to talk through all the things that uniquely as a young woman you think about, whether it's dating, whether it's fertility, whether it's mental health, whether it's feeling like the youngest person who has to deal with this and feeling like a freak or whatever that is. But the lack of community, and it's getting better, but the lack of community for women of color around breast cancer is still very much an issue. We just came out of Breast Cancer Awareness Month, and a lot of the images in the past and are, like I said, are getting better, but we still have a ways to go, aren't necessarily representative of all women. I think that folks are becoming more conscious of that, and there's more and more nonprofits that are cropping up where women can talk uniquely with folks from their community about their experiences. But I think that that's one of the biggest impacts on your mental and emotional health after a diagnosis, is feeling like you need that sense of community and you're not really sure how to navigate it on your own, being so young. So that's something that I'm involved with, and I know that a lot of people on here are involved with, including our lovely moderator. And conversations like this from the Pink Agenda are a part of the solution, talking about these issues, and including more and more organizations to consider disparities in breast cancer and how to make everyone feel included. So I'm optimistic about where we're going.
Yeah, absolutely, for sure. That was the thing. I was diagnosed at 36, I believe. And if I had a nickel for every time I've heard, "You're too young, what are you doing here?" I mean, I probably would have been able to pay for my chemo out of pocket like cash. But yeah, it was difficult finding someone that looked like me, that, got my jokes, that understood when I would say, "My mom, you're 36, you got to talk to your mom." Yes, I have to check in with my mom. It's difficult when you get this life altering diagnosis and you can't find someone who gets you. So I didn't find my people until 2 years after I was diagnosed. It's never too late, but it would have definitely helped, because most of my education around breast cancer and how to advocate for myself came from community. It came from someone who was like, "Oh, talk to your doctor about Claritin for bone pain, and ask them about why should you get the Neulasta shot on this day." It's important because the doctor has but so much time. So you need to come to these appointments ready, and it's community that helps. So I definitely agree with you, Alejandra. Community is key. Well, this is the last question, folks. For the last question, I want to hear from all of you. What makes you most hopeful about a future where all populations benefit equally from the progress made from research? Dr. Carey, I'll start with you.
I'm hopeful because, to be honest, I've been doing this now for 20 years. And what I see is an acceleration of the research. I see an acceleration of the collaboration between scientists and physicians. and partnerships with patients. I think, there's a feeling of, we really are all in this together, and let's identify the challenges and meet them together. And it used to be that the scientists lived in their corner and they played with fruit flies and yeast and whatever. And the clinicians saying like, help us, and the patients are like, what are you guys doing? We're doing the same thing we did yesterday. That's not the way we do things now. There's much more, investment and recognition of the importance of crosstalk, and really important, the voice of the patient, which is increasingly heard in grants, in initiatives, in, talking to scientists, talking not just through us, but directly. So those are all the kind of things those are parts of accelerators, and the technology and the capability that we have now scientifically to try and explore the nature of breast cancer, both primary early breast cancer and metastasis, has just so those all make me really excited. I also think that at the same time, we're all looking at how we do our work and how we live our lives through a different lens nowadays, recognizing that, you may live in your community, but there are a bunch of other communities that are not getting the same attention. And it's part of your role to make sure that they do, that we all need to bring everyone to the table and make sure that we have representation in our studies, and in the biology and biologic research that we do. It does feel like that's happening. And I think, to be honest, I think the breast cancer community, I've always thought we were leaders in everything. And this is another one. I think that we've been leaning forward into this for quite a few years.
Absolutely. Dr. Hirschman, what do you think?
Yeah, I think those are all like really great points. I feel really hopeful because, I think the world has changed, and there is, a lot more where there's more recognition, money follows. And when money follows, research discovery, comes out, bubbles out of it. And if the people with money are putting effort into understanding disparities and health and equity across the whole spectrum, and if our pharmaceutical partners are putting money into helping us understand and figure out mechanisms to get more patients on trials, like that at the end of the day, something will come out of that it's not just awareness, it's awareness plus action that I feel will lead to discovery that will help make some of this a little bit better.
Absolutely. Even if it's incremental, right? It's still something. Alejandra, what do you think? How do you feel? Feeling hopeful?
Well, health equity has a lot to do with health access. And, what makes me feel hopeful is seeing the activists and the advocates and all the voices that are working towards expanding and increasing health access so populations can have access to healthcare, to allow them to take advantage of the advancements in research and so on. And I think we have to keep doing that. And I'm not trying to get political here, so I won't get political, but I think it's important to continue to prioritize health equity and expand health access, because that's how we'll make sure that everyone has the same fighting chance.
Absolutely. I don't think it's not political to say that we've all noticed that the world, we all impact one another. And so, it doesn't matter what's in your pocket, how much you make a year, we all are affected by the decisions of the world. So I agree, Alejandra. Woo, guys, what a wonderful conversation. Thank you, Dr. Carey, Dr. Hirschman, and Alejandra for such a thoughtful and informative discussion. Though these conversations can be challenging, it's crucial to us and for us to continue to have them. Thank you, everyone out there in internet land, for joining us tonight on TPA Talks on the agenda, Disparities in Breast Cancer. Please refer to your digital program booklet or the Pink Agenda website for more information about upcoming TPA events and initiatives. Remember, you can continue to text TPA Talks together one word, to the number 44321 to support the Pink Agenda and the life-changing breast cancer research that it funds, including Dr. Hirschman's groundbreaking work that is truly improving outcomes for many women and men who face this devastating disease. Thank you so much, everybody. I appreciate it so much. Have a great, great night.